Welcome to today's Explainer. Look, we are staring down one of the absolute most ambitious transformation tasks in modern healthcare history, the NHS 10-year health plan. It is a massive, system-wide undertaking designed to pull a beloved institution back from a historic crossroads. But as anyone who has worked in complex systems knows, having a strategy and actually executing that strategy are two very, very different things. So today, we're going to explore how we can make sense of this monumental health plan using a completely unexpected source. We're looking at military doctrine. Specifically, we're going to see exactly what the NHS can learn from NATO planning.
Okay, let's dive into this. Here is our playbook for today. 1. The NHS meets NATO. 2. Start with the end. 3. Mapping lines of operation. 4. Finding centers of gravity. 5. Wargaming the reality. And 6. Continuous planning and adaptation.
Starting with Section 1, the NHS meets NATO.
Now, I know pairing public health care with military defense alliances sounds incredibly strange at first, but bear with me, because the shared reality here is actually striking. The NHS is currently facing ballooning waiting lists, massive demographic pressure, and a desperate need for radical shifts in how care is delivered. And this brilliantly illustrates why we're looking at NATO. NATO planning is explicitly designed for incredibly complex scenarios involving multiple independent actors, super scarce resources, and incredibly strict legal constraints, right? They both shared the massive, seemingly impossible challenge of linking high-level strategy to on-the-ground tactical execution in highly uncertain environments. To tackle this, we're pulling from AJP 5. This is NATO's Allied Joint Doctrine for the Planning of Operations. And let me be clear right up front. The NHS absolutely doesn't need some rigid, shouty military command culture. What it desperately needs, however, is the disciplined operational thinking found in the specific manual. It's about turning lofty national aspirations into a coordinated, adaptive campaign.
Moving to Section 2, start with the end. You know, large public systems often fail not because the ideas are bad, but because the journey itself is totally underdesigned. Dependencies get missed, and local leaders are just handed these massive national ambitions without a coherent operating design to actually pull it off. AJP 5 insists that to fix this, literally all planning must begin by clarifying 4 foundational pillars: ends, ways, means, and risks. Because too often healthcare plans just become disjointed collections of unlinked initiatives, like a new app over here, a new pop-up clinic over there. Instead, they need to be fully integrated designs. The ends are the actual concrete conditions required to attain the end state. The ways are how we sequence our actions to get there. The means are the real-world resources we need. And the risks, well, those are the uncertainties that could completely derail the whole shebang.
So the absolutely crucial point here is how we translate a grand national vision into measurable local conditions. Every local integrated care board needs to sit down and ask themselves a very specific, very tough question. What must be true in this place for the 10-year plan to have succeeded? If the goal is, say, shifting from hospital to community, that doesn't just mean launching a couple more community services. It means defining an end state where your local population actually experiences continuous, accessible, integrated care.
Which brings us to Section 3, mapping lines of operation. Okay, once we know our end state, we have to map the pathways of the campaign. In AJP 5, this is known as a line of operation. It's essentially a path linking decisive conditions together to achieve an objective. It arranges your actions in time, space, and purpose. For the folks doing the planning, these lines are a lifesaver. They help synchronize activity, establish real priorities, and measure progress over time. It basically takes the absolute chaos of transformation and puts it on a structured track.
Let's move to and see how this builds our primary framework using the raw material of the 10-year plan itself. The plan actually outlines 3 radical shifts, which honestly serve perfectly as our primary lines of operation. First, hospital to community. This requires decisive conditions like establishing neighborhood health centers and multidisciplinary teams. Second, analog to digital. That requires conditions like a truly single patient record and AI-enabled workflows. And third, sickness to prevention. That means taking decisive action on things like tobacco, obesity, and genomics-based population health.
But here is the catch. AJP 5 strictly warrants that these lines of operation cannot just be independent, siloed work streams. They have to be synchronized. Think about it. Digital tools directly enable community care. Prevention directly reduces future hospital demand. So the NHS needs a synchronization matrix showing exactly when and how actions across all these different lines combine to create a measurable system-wide effect. Now for Section 4, finding centers of gravity. To actually make those lines of operation work, we have to pinpoint our constraints before we start committing serious resources. In military doctrine, a center of gravity is a primary source of power. But translating that into a civilian transformation context, ask yourself this: what are the critical sources of system behavior that, if changed, would unlock the entire plan, and equally, if neglected, would cause the whole thing to fail? We have to move way beyond generic corporate risk registers and find the real systemic linchpins. Now, what's really interesting here is how identifying just one of these critical constraints can completely dictate the success of the entire operation. Look at resource flow, for instance. The plan requires the share of hospital expenditure to fall so out-of-hospital care can actually grow. Well, if money and staff remain locked in acute settings, community care fails, period. It becomes rhetorical rather than operational. Or take workforce capability. If the staff isn't trained for the new AI tools, that whole analog to digital shift just stalls out entirely. You absolutely must identify these constraints up front, protect them, and monitor them continuously.
That leads us to Section 5, wargaming the reality. Okay, so we're transitioning to what is arguably the most dynamic part of operational planning: stress testing the plan before reality forces you to. In healthcare, we really need to demystify this term wargaming. It's not about being pessimistic, it's a mark of serious professional planning. Wargaming is simply a structured rehearsal. It provides this incredible safe-to-fail environment where leaders can model how a transformation plan actually behaves under immense simulated pressure. It exposes the deficiencies and refines decision points long before real patients and real budgets are on the line.
Let's pressure test this together right now. What if creating a brand new digital front door actually spikes patient demand before it reduces it? What if those fancy new AI tools save admin time, but suddenly create massive new clinical governance bottlenecks? What if you open all these new community services, but the acute demand at the main hospital just doesn't fall quickly enough? Or what if empowering patient choice shifts activity so fast that your local providers simply can't adapt in time? You can't just cross your fingers and hope those what-if scenarios don't happen. AJP 5 demands that every major transformation has built-in decision support matrices ready to activate when they do happen. You have to define the exact trigger indicator. You must know exactly what information to gather, identify exactly who is making the call, and be ready to execute a fallback branch plan. If community capacity isn't available by a certain date, you must already know exactly what your pivot is. No scrambling allowed.
Finally, Section 6, continuous planning and adaptation.
If we want to break away from those static, dusty multi-year plans that completely fall apart the second the operating environment changes, we have to look at a crucial military concept called mission command. It's a simple phrase: centralized intent and decentralized execution. For the NHS, this means national leaders must set crystal clear outcomes, strict constraints, and high standards. But then, they must completely and utterly empower local leaders to decide how best to achieve those outcomes within their own specific local population context. The center shouldn't be micromanaging. It should just be monitoring whether those decisive conditions are being met.
Maintaining this requires establishing what military doctrine calls a battle rhythm. The NHS equivalent should be quarterly system transformation reviews. But listen carefully, these absolutely cannot just be disguised performance management meetings. They have to be planning and adaptation forums. You have to sit down and ask, which of our assumptions are now totally invalid? Which risks have actually materialized in the real world? Which lines of operation are currently out of sync? And which fallback plan do we need to activate today? Implementation has to be treated as a continuous, endless source of learning and adaptation. So, we've seen that the NHS 10-year plan has incredible strategic ambition, but it desperately needs this kind of operational design discipline to actually survive the real world. By defining end states, mapping out those lines of operation, finding our constraints, and wargaming the risks, a strategy finally becomes a coherent campaign. So I'm going to leave you with this final provocative thought. Take a hard look at your own healthcare environment, your own local system right now. Are you treating this transformation as just a loose list of unlinked programs, or is your local system actually ready for the campaign?